This will be in French. And at the outset, could I say what a tremendous pleasure and honor it is to be here with our German colleagues.
The recommendation on hemorrhagic shock and really we have a lot to learn by collaboration of this kind of collaboration inside the Europe. Donc,
I was saying, what should be our conclusions on vasopressors in hemorrhagic shock? My experience is with trauma, and this obviously can be extended to other forms of shock, massive bleeding in digestive hemorrhage or delivery hemorrhage. But all of these are specific, and I should be talking about what I know best, which is traumatology. Some concepts can be extended to other forms of hemorrhagic shock. There are two distinct phases in hemorrhagic shock. There is the pre-stabilization phase, and then after that comes the stage where you can bring your patient to resuscitation and then continue resuscitating the hemorrhagic shock. And I shall be addressing essentially the time until bleeding is brought under control. The idea is not to make any mistakes in the resuscitation stage and not increase the segment for such time as it is not under control. The idea then is to prevent dilution coagulopathy. In other words, try not to overfill and try to live with a degree of hypertension, what the Americans refer to as permissive hypotension, and get into aggressive therapy, aggressive transfusional strategy with BFM or fibrinogen, as we saw earlier on. And in other words, damage control. So in the recommendations, the European recommendations, we're now starting to see this idea of low-volume resuscitation and permissive hypertension. There is controversy as to the appropriate pressure level, because recommendation is great, but what level should be recommended? And we don't have much to go on in order to determine precisely the right level on the basis of the trials. The idea is that even if there's not much in the literature to give us a strong recommendation, to support a strong recommendation, it is recommended not to generate too high a pressure. 80 SAP of 80 to 90 seems about the right level. So what is the potential good news about vasopressors in hemorrhagic shock? Firstly, because when combined with vascular filling, it reduces tissue hyperperfusion and hypoxia until such time as the bleeding has been brought under control. And this is particularly the case when the hypertension does not react to filling. And there is another idea, which is that this could perhaps be a way for the same level of blood pressure to use a vasopressor combined with filling. But the fear is, are we not going to aggravate the segment if the objective, if the target is too high a pressure with the vasopressor? Is there not a risk for is there not a risk of vasoconstriction, which obviously would be harmful? But then, why use a vasopressor at all? Whereas in hemorrhagic shock, if I remember what I was taught, the sympathetic system is running at its maximum. So why add vasoconstriction to a system which is already very efficient? The first thing is that, as you know, when you have massive bleeding, a massively reduced return, there is the Jared reflex, which can suddenly lead to bradycardia and dilation. We've all had this in experienced this in massive bleeding with a major risk of collapse. And so here it is obvious that you need a vasopressor. The other thing being that in a patient, although we know the sympathetic system is going to be running 110%, but one of the things we do is in managing severe shock is that we're going to put the patient to sleep. In other words, we're going to reduce his capacity to have a system running at maximum efficiency. And so adding a vasopressor under such circumstances would be to boost the sympathetic effect in a patient who's been put to sleep and whose sympathetic system has been slowed down. And thirdly, very quickly, in traumatic injury comes inflammation due to tissue trauma or the bleeding itself. And then comes gradual appearance of inflammation and vasodilation. And so here, it's not just vasoconstriction that we will find as a response, but also dilatation, which is possibly going to be managed with a vasopressor. Now, I said earlier on that you may have a reflex-inducing bradycardia and vasodilation. However, let me show you a first example in experimental studies. Look at some of the vasopressor data. Here, the lesion is mesenteric. It's a very severe experimental hemorrhagic shock with MAP below 20, so very, very serious indeed. And if you compare a vasopressor strategy versus volume expansion, you'll see that no animal except one will survive expansion, whereas the vasopressor gets us through the tough patch, and we have more elbow room to resuscitate afterwards. This obviously is an extreme case, sub 20. Another experimental study on adding a vasopressor to expansion therapy, in this case noradrenaline, and this is a bleeding model in which initially there is spoil, and then comes uncontrolled bleeding induced by amputating the animal's tail. There are two arms, two groups, one in which you make sure that the pressure never drops below 40 millimeters, and the other in which it is never allowed to drop below 80. So two different pressure levels, and it's either expansion or plus expansion plus 5 or more gamma of noradrenaline. Now, the interesting thing, firstly, is that if the dose levels of noradrenaline are too high, there is a disastrous effect on the survival of the animals. So it's very important not to use too much. Confirming that noradrenaline is not the sole treatment for shock. However, at lower doses, compared to volume expansion, you can see here that adding noradrenaline to reasonable doses is a possible way of improving the mortality score. If we now combine the two groups, the two different pressure groups, you can see that the conclusion, the most interesting conclusion here, is that if you look at the groups with the blood pressure target is higher, on the right here, 80 millimeters, you can see that if you try to target this using filling alone, then you worsen mortality, probably by worsening coagulopathies. So be very careful, firstly, about the pressure level, And if you target a higher level using only filling, then sure enough, you can get it wrong and end up with a disastrous result. So we tried to confirm this. This is a mouse model. Hemorrhagic shock is induced. There are two strategies. One, filling only, 50 for an average pressure of 50, 60 when we're looking at mean pressure of 60. And then we have groups in which, in addition to filling, we add noradrenaline. And clearly, when you add noradrenaline, there is less aggravation of the segment than when you use only vascular filling. So noradrenaline plus filling is plus expansion reduces the loss of blood regardless of the pressure level, 50 or 60. This is the relevant conclusion here. So this may be good news, but are we not inducing excessive vasoconstriction? This was the whole purpose in the study. We looked at the microcirculation and we looked at the splanchnic circulation in these animals, and at the end of the bleeding, when you look at capillary density, this obviously is hemorrhage, so we have RBCs down, fewer red blood cells passing through during the test. But noradrenaline blocks off microcirculation. In other words, pressure drops. And if you look at capillary density, you'll see that it is unaffected by the fact that we have added noradrenaline in addition to filling. And if we now take, here we take yet another group, animal group, with the same idea. And we looked at PO2, in intestinal PO2, so as to have both perfusion and PO2. And you can see that in terms of PO2, we have no alteration in PO2 when we use noradrenaline. So even though these are, and obviously this is a borderline case, but it is a demonstration that if you use reasonable levels of noradrenaline in addition to filling, you do not worsen microcirculation, at least in this group. And at the present time, we are trying to confirm this concept with our patients. And as further confirmation, why is this not harmful to microcirculation? Simply because a catecholamine, like noradrenaline, is not just a constrictor. It also mobilizes venous blood. This is a hemorrhagic shock model on dogs. And you can see that they induce bleeding and then use noradrenaline without filling. It's noradrenaline only. And if you look at the cardiac index, the result is a delta, simply an increase just by adding noradrenaline. This may be the beta effect of the noradrenaline, but it is certainly also because blood is being mobilized and the venous return effect induced by noradrenaline, which is very elegantly demonstrated by Xavier Monet in septic shock, taking peripheral venous pressure on noradrenaline in septic shock patients, correlating central venous pressure and cardiac index, studying reduced venous return, and he showed that noradrenaline contributes to an improved relationship and generates a positive effect in terms of venous return. So I showed you the experimental studies. Now, what about in vivo? What about in man? We have very little literature available. This is a study done in American trauma centers with more than 1,000 patients. patients. This was not originally designed to address the impact of vasopressors in the management of traumatic hemorrhagic shock. This is simply the course of patients over the course of the trauma episode. And so they looked at patients depending on whether or not they'd been given vasopressin, and those that had been had received crystalloid filling. And when you take patients having had vasopressor only in resuscitation, noradrenaline, dopamine, or vasopressin, so they consider that dopamine is a vasopressor, you can see we've got a bit of leeway. This is why it's so important to work at European level. And you can see there is a harmful effect in terms of mortality when vasopressors are used. However, resuscitation, crystalloid resuscitation, was not harmful in this study. However, since the study was not designed for that purpose, in other words, the groups with or without vasopressin are properly balanced. And when you're looking at the vasopressor group, if you're not actually looking at patients who are in a more severe case than those without vasopressors, and so in fact all you're showing is that the most severe cases die. But when you read this thoroughly, and I'll give you an example here, it may look as though the groups are not balanced, because if you take the group with an early thoracotomy, which is a factor of aggravation in and of itself, you can see that the group that was filled is 19 versus 4. And I could give you other examples showing that probably they were looking at the most severely traumatic cases in the vasopressor group. And if you look now at noradrenaline or vasopressin, there is, in actual fact, no increase in mortality with the two vasopressors, and the increase in mortality comes with phenylephrine, which is a pure alpha, and dopamine. So lots of unanswered questions out there, and no formal conclusion in terms of the potentially harmful effect of vasopressors when used in hemorrhagic shock. Another American trial here, a retrospective study, 1,349 patients, where they come up once again with increased mortality in the vasopressor group, 43% when a vasopressor is used versus 4% mortality when no vasopressor is used. However, if you look at the mortality figures, 43% mortality in trauma, these are very severely traumatic patients, because all in, the average figure is 14% in trauma patients. So once again, it's rather difficult to draw firm conclusions. So there's a question of strategy here. How are vasopressors being used? We clearly are not using them the same way as the Americans. In management, pre-hospital, the Americans doing this are paramedics. They very seldom have access to vasopressors, so there is an entire phase during which patients, they're trying to get them to hospital as quickly as possible. They're underfilled, no vasopressors. And here, what I'm showing you is the first study. It looks at our trauma practice and methods, and you can see that our methods clearly are not the same. So no apples and pears. Here, catecholamine with the infusions given over the course of time, and the difference is massive. So it's very interesting to assess our respective practices. These European and original. one single randomized study, and it concerns vasopressin, double-blind. It's a small series, no relevant conclusions on mortality, but it does show that when you use a vasopressor, you reduce the amount of liquid required to manage the patient. You also reduce the amount of blood product required, and this is extremely important. Bolus, then IV, in this study. For the first time in the recommendations, we see the fact that administering a vasopressor may be considered as a way of keeping blood pressure up. So if there is no response to filling, and as a conclusion, I would say that vasopressors can help us to restore blood pressure and limit tissue perfusion. This is in cases where there is a failure in maintaining pressure during filling, but let's be reasonable. I mean, the prime treatment is filling, but vasopressors can be a useful adjunct, can help us with filling, and can limit the type of coagulopathy problems that can arise in such cases. However, it's important to be very, very careful about respecting the